Good afternoon. Thank you for joining the We Can Educational Series. Today, Dr. Angela Rabbitt will discuss commercial sex trafficking of children. The handouts area includes a PDF of today's slides, as well as a PDF with details on the following housekeeping items. To ask a question, you can use the question pane on the control panel. Questions will be addressed at scheduled breaks. To obtain continuing education credits for today's session, you must track your attendance by texting today's code to the phone number on the screen. The code and phone number will be displayed at the end of today's session. This training has been approved for MOC Part 2 continuing education credit for physicians. You must complete a knowledge quiz at the end of this training. The link to the knowledge quiz will be displayed on the screen.
Okay, hello everyone. My name is Angela Rabbitt. I am an associate professor of pediatrics at the Medical College of Wisconsin in the Child Advocacy Program. In my role at the Medical College, I perform medical evaluations when kids come in with concerns for child maltreatment, including human trafficking. And also over the last several years, I've been working really closely with the community and with other healthcare systems in Milwaukee to create responses to trafficking that will hopefully reduce health disparities in this population. So today I'd like to talk about some of these initiatives in Milwaukee and Wisconsin, as well as some of the background research that went into the development of those. And I have no conflicts of interest. So we do know from research and from our own experiences that victims and survivors of human trafficking have higher rates of many medical conditions, including mental health disorders, chronic untreated medical conditions, reproductive health care issues, and substance abuse disorders, just to name a few. And to give you a couple of examples from our own populations, in 2014, our research group looked at the health records of trafficked youth presenting to 3 high-risk clinics in Milwaukee in that year to better understand their medical needs. Out of the 143 youth that were identified during that time period, 86% had been diagnosed with chlamydia, almost half with gonorrhea, and a quarter with trichomonas. And these numbers obviously are much higher than in the general population of youth of this age. And this graph shows the rates of mental health disorders in our population compared to general populations of youth. And this is according to the National Comorbidity Study, which is a nationally representative survey assessing the prevalence of mental health disorders. The blue bars are our trafficked population in Milwaukee according to that data from 2014. And as you can see, there's a significant difference between these two. 90% of our population had at least one mental health diagnosis. 71% had between 2 to 5 diagnoses, and 11% had between 6 and 9 diagnoses. And really, this does kind of make sense when you consider the physical and psychological violence inherent in human trafficking. Also, I think in some cases, an existing mental health disorder is what actually makes the youth vulnerable to traffickers in the first place. But even among other groups of high-risk youth who have likely had similar experiences of maltreatment, which are much higher in trafficked youth, rates of mental health issues are higher among youth who are trafficked compared to those groups. So this data is from a study a medical student and I did in 2019, comparing the rates of mental health disorders between youth who are trafficked in Milwaukee compared to runaways, youth in juvenile detention, and youth in foster care. So these were comparisons with literature-based prevalence. And again, the rates of mental health disorders among trafficked youth were higher. And this is particularly impactful when you consider these other populations probably also contain some youth who are being trafficked. So that's a preliminary study, and it needs further validation with a local control group, but I think it does suggest the impact of complex trauma on youth who are trafficked is significant, and most importantly, that it's different than other groups of high-risk youth, and more specialized services are needed for this population. Research also shows us these health disparities continue and may even intensify into adulthood. Even if victims are able to leave the trafficking situation, the trauma can continue due to the stigma of prostitution and societal blame for the victimization. They sometimes feel, according to surveys of victims and survivors, like they can't return to their homes and communities because they'll be pre-identified as being sex workers. So they experience continued fear, distrust, humiliation, continued stress and anger. Many are trafficked at a very young age and so don't develop the life skills or complete the education needed to function outside the life of trafficking, making them feel really pretty trapped and hopeless. They also report more significant somatic symptoms, poor quality sleep, insomnia, and nightmares related to post-traumatic stress, which makes day-to-day functioning pretty difficult. And many have few social connections outside of the life, limiting their healthy support options. So as a result, it can be really difficult for survivors and victims to leave their trafficker. Similar to victims of domestic violence who might return to perpetrators multiple times before they're able to leave for good, recovery from trafficking is a process that often involves relapses into the life with continued trauma. So all of these things can impact their ability to seek care and our ability to care for them appropriately. And people talk a lot about health equity, but what does that really mean? What does it really mean to improve health equity for a population? Health disparities are differences in health between groups of people closely linked to economic, social, or environmental disadvantages. Disparities adversely affect groups of people who have systematically experienced more social or economic obstacles due to any cause. It could be race, location, economic disadvantage, or many other reasons. So fostering health equity means trying to reduce health disparities by addressing the root cause of those disparities. And that really means understanding the barriers to health and what structural changes like policies and workflows and what more internal changes like relationships, power dynamics, and mental models are needed to address the disparities. It also involves developing relationships with community agencies that can provide important resources outside of the healthcare system that can have such a huge impact on our patients' health. So today I'll talk about victim and survivors' perspectives on those important community resources that anybody working with people impacted by trafficking should be aware of. We'll discuss both youth and adult survivors of trafficking, what they feel are important healthcare needs, and the barriers they experience to accessing care. And finally, we'll review what the literature says about model responses to improve health equity in this population and some efforts in Milwaukee that many people who are listening to this, both medical and non-medical, could be involved with. First, I always want to make sure we're starting on the same page. There are a lot of myths about what sex trafficking is, and it seems like even among people who work with victims, there are variations in understanding. So here is the federal definition, which is very similar to Wisconsin's definition. Sex trafficking is the recruitment, transportation, harboring, providing, obtaining, patronizing, or soliciting of a person or attempts to do so by means of force, fraud, or coercion for the purpose of a commercial sex act, which is sexual contact for which anything is given to, promised, or received by any person. And there's some things to note about this definition. I think it's important to remember coercion can look like many different things. Sometimes coercion is a threat of violence against the individual or their family. Sometimes it's threats of deportation. It can be the trafficker exploiting an addiction or exploiting a cognitive impairment that the victim has. It's really about taking advantage of a vulnerability in order to gain control over another person. And the coercion may not be immediately obvious to you or even to the victim at that time. Also note that the definition of commercial sex act is very broad. It can include dancing, stripping, pornography, and also note sexual contact for which anything is given to, promised, or received. So that can include survival needs, drugs, money, or even sometimes can include protection, as in a gang situation. The definition is a bit different for minors. However, in Wisconsin, a minor is anyone less than 18 years of age. According to state law, minors are legally incapable of consenting to sexual contact with adults. So coercion is implied. And then this whole middle box here drops out of the equation. Claudine O'Leary, who is a youth advocate in Milwaukee, worked on wording of a definition with a group of youth survivors. And this is what they came up with. I think it's worded well and is also in line with our state's definition of sex trafficking in minors and is a definition that youth understand. So sex trafficking of a minor is any form of being sexual or the idea of being sexual in exchange for money, gifts, safety, drugs, hormones, or survival needs like housing, food, clothing, transportation, healthcare, and documentation. Whether we get to keep the money or resources or whether someone else takes some or all of the money or resources. I think here is one of the biggest points of confusion on the definition for minors as well. Sometimes we see juveniles who say they're doing this all on their own. They say they're setting up their own dates and keeping the money, that there's no pimp or third-party trafficker who's receiving that something of value. But according to federal and state law, this is still considered trafficking if the person is less than 18 years of age. Remember, anyone who patronizes a minor for the purpose of a commercial sex act is guilty of trafficking. So in a case without a third-party trafficker and a youth, the buyer then is the trafficker. From a mandatory reporter perspective, we don't distinguish between someone who has a trafficker and a minor who says that they're doing it all on their own. The resource needs are really the same. They're often experiencing the same violence. And often with further investigation, we find that someone else is actually benefiting from that commercial sex act. If you look at surveys of victims, most describe that they did have some exposure to healthcare during their exploitation. This is one example. These numbers are from a national study conducting focus groups, surveys, and interviews of survivors, looking back at their experience being trafficked. 88% had some contact with healthcare during their exploitation, and most were seen in the emergency department, but also many were seen in a clinical setting. The interesting thing is that when we do presentations to healthcare providers, often they tell us they don't really see this population very often. But in this study, during interviews with victims, researchers found that many opportunities for identification were missed. Though practitioners recognized that victims were on the street, very few had been asked, or providers realized that a patient had a pimp or a trafficker. I mentioned earlier our research group looked at the number of youth being seen in 3 high-risk clinics in Milwaukee in 2014. One was a clinic with a juvenile detention center. One was a clinic with a mental health organization that works with high-risk youth. And the other was an adolescent health clinic in inner-city Milwaukee. These 143 youth who had disclosed sex trafficking or someone else, like law enforcement or child protective services, identified that the youth was being trafficked. So that was the population. We saw over 10 youth per month that year who were presenting with these concerns or had been trafficked at some point in the past. And then in my clinic, the Milwaukee Child Advocacy Center, 11% of youth being seen for foster care evaluations disclosed that they'd been trafficked at some point of their lives when we did routine screening of all foster care kids. And these were kids with a lot of risk factors, so I'm not saying we would expect these numbers in a general pediatrics clinic, but it is certainly something that providers are likely to see if you work with high-risk populations. I think it also highlights that when healthcare providers asked in a sensitive and trauma-informed way, many youth were willing to talk about what happened to them. I'll show you in a little bit the numbers of youth identified in Milwaukee and how it's been kind of increasing over the last few years. I think part of the reason for that is improved awareness in our community. Also, there's been a big push nationally by health systems to improve identification and responses to human trafficking. Over the last several years, multiple national organizations, including the ones you see here, are calling for integration of education and strategies to improve the response to human trafficking within healthcare curricula and healthcare protocols. More locally, sex trafficking has been identified as a priority area for the Milwaukee Healthcare Partnership in response to Milwaukee's Violence Prevention Initiative, which is the Blueprint for Peace. For those of you who aren't familiar, the Milwaukee Healthcare Partnership is an organization of major health systems, community health centers, and organizations committed to improving access to healthcare for underserved populations. In particular, of these organizations, I wanted to point you to the American Hospital Association website. This this website provides some great information and resources to help build a response to human trafficking within healthcare organizations, and that's through their Hospitals Against Violence initiative. So hopefully I've laid some foundation for why unique solutions are needed to improve health equity for survivors. As I mentioned, to address the causes of poor health in a population, it's important to understand the root causes of the barriers. So we've done some work to try and understand this in Milwaukee, and I'd like to spend some time talking about that next. Before I do, though, there are a couple of organizations I need to introduce. POSI is one. This was a grant-funded project that had a goal of improving education and awareness of trafficking among healthcare providers in Milwaukee. POSI is the Proactive Outreach for the Health of Sexually Exploited Youth. This was the group that gathered the 2014 healthcare data I mentioned earlier. Also, as part of this project, we did a needs assessment of healthcare providers to understand their perspectives on barriers to caring for youth who are trafficked. And we did focus groups of youth to get their perspectives on working with healthcare providers as well. The Child Abuse Review Team, or CART, is comprised of representatives from agencies across Milwaukee that would be involved in an investigation for child maltreatment. So this group created the Milwaukee County Joint Protocol on a collaborative response to child maltreatment. The Joint Protocol is a document that outlines how these agencies will work together to ensure high-quality investigations that not only maximize child safety, but also minimize additional trauma to the child and to the family. So the POSI Needs Assessment was conducted between 2014 and 2016. It included a statewide survey of healthcare providers and medical social workers, listening sessions with healthcare providers, and a review of the literature. So the big themes that emerged will probably not be surprising to any of the providers on the call. Providers didn't feel confident in their ability to recognize or provide appropriate care, often due to lack of training, and because they didn't know where to refer trafficked patients for community services. They also didn't feel confident that if they made reports to CPS or law enforcement, that would lead to beneficial actions and services for the youth. This slide shows some information from the statewide survey we conducted of healthcare providers and medical social workers. We found that less than half could correctly classify individuals as being trafficked. 90% of providers and almost 80% of social workers didn't feel confident in identification, screening, or response, but there was a lot of interest in learning more. This group also felt, the participants felt, the most important barriers to effective responses were lack of education and lack of response guidelines within healthcare organizations. Because of this uncertainty among healthcare providers about the investigative and community response, one initiative of POSI was to better understand what the investigative response entails and to collaborate to improve how we could work with outside agencies as healthcare providers. So we partnered with CART, and at that time, CART was also really feeling the need for improved collaboration among community agencies that served trafficked youth. CART meets once a month to review systems problems, and those meetings were just being overrun with trafficking cases that had gone wrong or did not have an ideal response. So CART formed a subcommittee, and we spent a long time in this subcommittee trying to understand the barriers in the community. These are a few things that we came up with. Though there was a lot of interest in human trafficking, efforts within the community were really siloed. At one point in Milwaukee, there were at least 4 task forces or organizations trying to develop a screening tool, and none of them really knew about each other. There were multiple trainings developed by agencies, but some were not providing accurate information. When we first started meeting, agencies really weren't even agreeing on a common definition for trafficking in minors. There were a lot of assumptions also, I think, and miscommunications happening between agencies that stemmed often from a poor understanding of agency roles and processes. But most importantly, agencies often were not communicating until problems had already occurred. We suffered, and really still do to some extent, like all areas, well, to a large extent, with a lack of community resources. In particular, Wisconsin at that time had just passed the advocate accompaniment law, which required hospitals with emergency services to notify sexual assault victims of their right to an advocate. But we had a really non-existent pool of advocates, especially that could respond after hours. There were some disagreements and concerns as well about what information could be shared, but also what information should be shared between agencies. But really, even more important than eliciting information from healthcare and community agencies is getting the perspective of people who are experiencing the disparities. So through POSI and then in preparation for our next project that I'll discuss in a minute, we did some focus groups of both youth and adult victims and survivors. And really all of the aspects of these initiatives working directly with survivors has really been the most illuminating and most impactful part of it. No matter how many journal articles or books you read or how much research someone does, no one is an expert in human trafficking unless they've actually experienced it. So I think survivors' input is absolutely essential to improving responses. And I want to stress really that all of the work that's being done is about amplifying survivor voices. So the adult focus groups were conducted with women recruited from 6 local agencies. Participants included women ages 18 and older. More work definitely needs to be done to include men, but we just had to get started somewhere, and male victims are pretty difficult to find. I think that's not necessarily because trafficking of males is rare, but I think there's more of a stigma around trafficking of males that impacts identification. The youth focus groups were participating in peer group sessions through Rethink Resources and Pathfinders in Milwaukee. So the groups occurred during those peer support groups. We asked about their perspectives on their healthcare needs, what could be done to improve experiences in healthcare, how they would prefer to be asked about involvement in trafficking, and what healthcare providers should know to better care for them. And these are the highlights of the youth focus groups. They saw healthcare providers as a resource that they would expect should know about human trafficking and should be able to help them. It was interesting that many healthcare providers in our listening sessions didn't think that youth wanted us to pry into their lives and that youth felt kind of uncomfortable with it. But these youth thought that healthcare providers should be asking about safety and trafficking routinely because they don't always know how to bring it up. In fact, most said they wouldn't have known what trafficking was when they were going through it. So providers should ask about it using examples and in ways that they'll understand. They also thought it is more uncomfortable if the provider seems uncomfortable and kind of dances around the issue. So most wanted to be asked privately. And they thought that speaking to adolescents alone as a routine practice was a good idea. Trust is a big issue with victims of trafficking, and that makes a lot of sense considering they so often have a history of child maltreatment and also coercion by traffickers. So being open and discussing mandatory reporting requirements with them before asking sensitive questions was recommended by youth in these groups. One of the biggest barriers to disclosure was the concern of bias based on race and stigmatization, that this idea that because they've been trafficked, they'll be seen as like bad kids or criminals or prostitutes. They really wanted providers to be educated that involvement in human trafficking isn't a choice, it's exploitation. And then for adults, though there are some similarities, the barriers are very different. There are more resources for youth in terms of shelter, housing, and case management. But then as soon as people turn 18 and are out of the child welfare system, they're often left to fend for themselves. At least that's the perspective of many adult survivors, and I think it's probably true. Many adults had issues obtaining health insurance, sometimes because they had no permanent address. but often because they had trouble navigating the system to obtain Medicaid. And then if they do have Medicaid, subspecialists often don't take Medicaid, so they have trouble especially accessing those subspecialty services. They appreciated free health clinics, but often felt the quality was poor, and they felt very rushed, like they were in an assembly line. Adults tell us that traffickers have an interest in keeping young victims healthy because youth can be more valuable. They can make more money for traffickers. So even though youth also experience extreme violence, traffickers may be more likely to allow medical care for youth. Adults stated that coming to a medical clinic or emergency department was often really very difficult because it was like taking time away from work, from meeting traffickers' quotas, or from securing basic needs for themselves or for their families. And many survivors just weren't educated about healthcare services that could be beneficial to them, so they didn't know how to ask. For example, many didn't know about the availability of prophylactic medications that could prevent sexually transmitted infections or pregnancies, or the availability of HIV pre-exposure prophylaxis. Some of the victim barriers include just having a trafficker. He or she would often come with them to the exam room to make sure that the victim didn't disclose. One of the biggest barriers to seeking medical care and disclosure, though, and this was the same for youth, was this fear of judgment and stigmatization. And actually, many of the participants in the focus groups described some really terrible treatment by healthcare providers and staff. One particularly impactful story, I thought, was by a survivor who now works as a medical assistant. She said that when someone comes into the clinic now who reminds her of what she was like during the time she was trafficked, she's really glad that her colleagues don't know anything about her past because she hears how they talk about that patient amongst each other. One survivor also told us that during a hospitalization, she overheard staff speaking negatively about her as a prostitute. And she had finally gotten the courage to seek medical care for her injury, but she immediately left against medical advice after hearing that. Some survivors talked about how difficult it is to repeatedly answer sensitive questions multiple times during the visit, and that they didn't always understand why providers needed to know the information. So taking time to explain the context of those questions would have been really helpful to them. Fear of being found by the trafficker and lack of confidentiality was also a big concern by survivors. So they felt, it's really important for healthcare providers to outline how their information is kept confidential. Many felt that another problem with the stigma of prostitution and human trafficking was that providers only screen for trafficking when the patient seems to fit their idea of what a victim should look like. They really wanted to emphasize that there's no face to human trafficking and that all patients should be routinely screened for violence in relationships. Autonomy was also stressed as very important. Victims so often are not able to make choices for themselves, and so it's very important to offer options and partner with them to find out what will work best for them. And then finally, like youth, they felt healthcare should be sort of a gateway to community services, but that those healthcare community partnerships just often aren't there. In every focus group, participants also emphasize that advocacy, especially by someone who has had personal experience with human trafficking, was something that really helped them get out of the trafficking situation and helped them navigate systems. So that's kind of a quick overview of some of the major barriers. I wanted to spend the rest of the time on a more positive note, like talking about what can be done about this, but there are many, many more things more information that we had gotten from the focus groups. And if anyone is interested in hearing more about that, I'm happy to talk about that, and you can contact me later. Also, all of that information is going to be published at some point. We're working on manuscripts now. I really want to stress for the rest of this presentation that Milwaukee obviously has not built the perfect response. I don't think the response is perfect anywhere, but we're definitely doing better than we were doing 5 or 10 years ago. The first thing we did in the CART group was to try to find some information about best practice responses, both at the state and community level. So in summary, these are some of the things that have been identified as promising practices. Having a screening or identification method in the various agencies that work with at-risk individuals is important, and the screening should be tailored and fit into the processes already in that organization. Having a plan for how to respond immediately is important. Often there's a narrow window when an individual is willing to get help, but they can give up very quickly if they perceive that help won't be provided. Advocacy and coordination services formed approaches to engage victims in services, and then wraparound services that use existing multidisciplinary teams, and finally, regular review of protocols and data collection for that area so you can monitor how things are going. So the subcommittee of CART, which is comprised of Milwaukee's multidisciplinary team, created some response guidelines to outline how agencies would work together to address trafficking of youth. We started by creating common classifications of human trafficking and outlining the response of each agency depending on the classification. So these are our tiers. Tier 1 youth are those that are actively disclosing or that come in with law enforcement. So law enforcement is already involved. Tier 2 cases are those with multiple risk factors, or someone else reports knowledge that the youth is being trafficked, but the youth isn't really disclosing. Responses by agencies depend on, Tier 3 are kids with multiple risk factors, but no one is saying that they know the child is being trafficked and the youth is not disclosing. The responses really depend on these classifications. So for example, law enforcement felt that in some cases, trying to get information from a child who isn't willing to talk can be very counterproductive, and it's not always in the child's best interest in terms of building trust. So it's better to provide services and wait until he or she is ready to talk. This is really a recognition that the needs of the youth are the priority. So law enforcement responds as quickly as possible to Tier 1 cases, but may not respond immediately when the child is not actively disclosing. Tier 3 cases have multiple risk factors, as I said, but no allegations, and those and Tier 2 cases might meet mandatory reporting thresholds, but they may not be screened in by Child Protective Services for an investigation unless they have information that increases the concern. They just may not meet that threshold for screen-in. In order to improve coordination early in the investigation, a human trafficking coordinator position within the Child Advocacy Center in Milwaukee was created. Her role is to ensure that all agency partners are aware of concerns and have been contacted when it's appropriate. And then if it's deemed appropriate by the team, she arranges a meeting of the multidisciplinary team that are involved with that youth to discuss the case early in the investigation. And that's to improve that early coordination of services. And then she goes on and helps with ongoing communication throughout the case. She helps coordinate advocacy services during healthcare visits for the youth and helps educate agency professionals on trafficking-specific services that are available throughout the county. She also provides case tracking and data collection for the multidisciplinary team. Tier 1 and 2 cases that are screened in by Child Protective Services are referred to the coordinator, and other agencies will refer all other tiers. These are just a little bit of our results. This table shows the number of youth referred to the coordinator since we started in 2016. The number of referrals by community agencies is in orange, and the blue are referrals by medical providers. So some of the examples of successes for this group are also listed over here on the right. This is information from 2020. Over half of trafficked youth were connected to community advocates, which is a huge improvement compared to 3% in 2017. 77% of youth who were offered medical care in 2020 received it, where, more commonly in the past, youth refusal of medical care or youth that are lost to follow-up would be the norm. The use of forensic interviewers with specialized training in sex trafficking, which is considered best practice, doubled from the typical average in 2020. So for healthcare providers, even though the community response will never be perfect, it's not anywhere, it is helpful to know there's a plan to ensure we're working together. And most importantly, I think this whole process really is evidence of the commitment within our community to help these youth and recognition that they are victims of a crime. So that's pretty inspiring. I also wanted to briefly discuss some other community responses developed over the last few years. I mentioned earlier that Wisconsin passed the Advocacy and Accompaniment Law in 2016 that required hospitals to notify victims of sexual assault of the right to an advocate. Recognizing the need for advocates, various agencies in Milwaukee banded together to create CRAE. CRAE is Collaborative Rapid Advocacy for Youth. They will provide urgent accompaniment to victims of human trafficking up to age 25. They're not 24/7 response, but they do have some expanded hours to respond in the evenings. So if you want more information, this is some contact information for you, or you can get copies of CRAE cards and more information about their services. These are responses available in Milwaukee County, and obviously it may be different in other areas of Wisconsin. However, the Department of Children and Families has been working to increase service capacity and standardize the process throughout the state. One of those initiatives was the development of regional hubs throughout the state. The purpose of those hubs is to promote public awareness and prevention in the region and strengthen statewide collaboration. Public and private agencies can apply to become regional hubs when new hubs are opened. Right now, regions 2, 3, and 4, here you can see on the map, do have identified regional hub specialists also who serve as experts in their respective regions. They assist child welfare and other community agencies with developing a response plan for cases of sex trafficking and identifying current and emerging services appropriate for youth. The specialists are listed here, and those are people who can help you find local resources. So those are some of the community initiatives to address human trafficking. There are certainly others happening, but these were some that were directly impacting healthcare. So before I move on to some initiatives within healthcare, does anyone have any questions? I'll pause here.
We have a couple. How has COVID affected kids who are being trafficked?
That is a great question. As you could see from that table of referrals to the coordinator, it really didn't slow down. When I talk to community agencies, however, they say that a lot of the trafficking kind of has moved online, and that's been one difference.
Okay, great. And do you have recommendations for screening tools that staff should use?
I sent a handout ahead of that goes along with this presentation that has response protocol guidelines. That's a separate sheet from the flow sheet. You can look on there, and there are some great examples of different types of screening tools. Some of them are validated. Some of them are recommended by agencies around the area, and some of them are from our survivor advisory board that created some questions they felt would be beneficial for agencies that are screening for trafficking. So I would just point you to those lists for some examples.
Yes, and there's a couple different handouts in the handout section today. So there is a copy of the slides, but also a few different handouts. What
Yes.
kind of training is required for the community advocates that are required by Act 351?
So the CRAE advocates are all medical legal advocates. So they do have training requirements that have to meet statewide standards. They have to actually meet those standards to be part of CRAE. And they also have human trafficking specific training that's been provided by experts in the community. So I'm not sure if every advocacy agency follows that and has those types of advocates, but if you're looking for advocates through CRAE, you can be assured that they have specialized training in human trafficking.
Thank you. That's all the questions we have right now.
Okay. All right, so after POSI, our next step was to work on improved responses within health systems, and that's what HCAST is about. HCAST is the Healthcare Collaborative Against Sex Trafficking. It's a project funded in part by the Advancing Healthier Wisconsin Endowment. The vision of HCAST is to be the hub of information and resources for healthcare providers and healthcare systems caring for patients impacted by sex trafficking in Wisconsin. We spent about a year and a half building partnerships for HCAST. As you can see, our team consists of representatives from all major health systems in Milwaukee. We're also working in partnership with multiple community agencies that specialize in the care of sex trafficking victims and with the Milwaukee Healthcare Partnership to help us reach executive level leadership within the organizations. We also have a group of survivors that's involved in every work group and every aspect of planning for this initiative. The focus groups we did for adults was part of the pre-planning for the HCAST project. We then took all of that information from youth and adult focus groups and the POSI needs assessment to HCAST, to our larger group, to create a charter and a strategic plan. This is the plan in a nutshell: to partner with the Human Trafficking Task Force of Greater Milwaukee to create a list of community resources with specialized services for victims. This list has been created and it's currently being vetted by HCAST members and by our survivor board. To ensure that those resources stay regularly updated and are accessible to everyone, they'll be housed within Impact 211's resource repository with tags for human trafficking. We're currently in the process of developing training a website to house those resources that should be up and running soon. They'll be available to all healthcare systems and community service agencies, but we'll really try to initially focus implementation through quality improvement projects in 1 or 2 healthcare sites located in areas with a high prevalence of trafficking. So we've started planning for that process. In the last part of this presentation, I wanted to walk through some of the best practices in healthcare that were identified in the literature and also through our work on HCAST. These recommendations center around 3 main points: the importance of trauma-informed approaches, utilizing harm reduction strategies, and facilitating access to social determinants of health. Access to agencies that can address social determinants of health. I think these 3 concepts are really essential to incorporate into patient care for victims of trafficking. So again, in your handouts, you have a copy of the standard of care recommendations for primary care that was developed by HCAST. Information about barriers to quality health care identified through the focus groups and the needs assessments were used to create key action areas to improve the healthcare response. And those are all grounded in those concepts of trauma-informed care, harm reduction, and access to resources. Then the standard of care work group of HCAS did an extensive literature search to identify best practice responses. Those were all compiled into a set of recommendations and then reviewed by our Survivor Advisory Board, by healthcare leaders in Milwaukee through the Healthcare Partnership, and by HEAL. HEAL is Healthcare Education Advocacy and Linkage. That's a national organization working to improve the healthcare response at a national level. So these have definitely been well vetted. I know most of you have likely heard of and been trained in trauma-informed care. If you haven't, that's definitely some training that you should seek out, because it will give you some great strategies for communication about difficult topics. But it's really just an abstract concept until you know how to apply it to your practice. The Substance Abuse and Mental Health Services Administration, SAMHSA, has published some really useful guidelines that can be used to develop trauma-informed approaches within organizations. But I wanted to briefly review a couple of these concepts with you in the context of sex trafficking. So first, creating a safe environment, not only physically safe, but also psychologically safe. And I mentioned in our focus groups that the most common barrier to disclosing victimization in a healthcare setting was this feeling of being judged or stigmatized. Trust is a huge problem. So following through on things that you say you will do, helping them understand why you're asking certain questions that seem sensitive and what you plan to do with that information can help build trust. We've talked a lot about the importance of peer support, especially from other survivors. And then collaboration and empowerment, finding opportunities to give them choices in their care and what happens to them. Cultural, historical, and gender issues, I think, go along with psychological safety for all patients. But an example of a common issue we see in trafficking is that survivors will sometimes request a provider of a certain age, gender, or race. Sensitive questions and exams can trigger a trauma response when the provider reminds the patient of their perpetrator. So trying to create diversity in the schedule and in the provider pool to accommodate those requests when possible is one example of a trauma-informed organizational initiative. Then there's this concept of harm reduction, which are interventions aimed at reducing the negative effects of health behaviors without necessarily extinguishing the problematic behaviors completely. I think there's a misconception in the general community that victims of trafficking are, all stolen off the streets into a white van at gunpoint, and we just need to rescue them and they can rejoin society. But as I mentioned before, the reality is that this is often a spectrum of recovery, much like we see with domestic violence, and that it often involves relapses into the life. But providers who expect that a person should just be able to stop, and then they then can get really frustrated and then don't understand when that doesn't happen. So it's important, like in education around human trafficking, to stress that the goal of the healthcare provider isn't to rescue or even to get a disclosure from a youth. It's to be a trusted source of information and assistance when that patient is ready to seek help. So for a patient who isn't able to leave the life, the approach should be harm reduction. This is really true in all aspects of medicine. It's unrealistic to expect patients to follow medical advice to perfection. So we shoot for the goals that are achievable for the patient. This is a quote from a study evaluating 3 service organizations serving minor victims of trafficking in San Francisco, Chicago, and New York City. The goal was to assess the characteristics of youth who are trafficked, what services are needed, and recommendations to improve responses. One of the organizations said this: we noted that young people engaged in sex trades as the least bad solution to meeting fundamental needs for safety, shelter, social connection, and love. Sex trafficking was never the only problem, and often not the most critical problem in young people's lives. So meeting those basic needs takes precedence over addressing trafficking, and creating connections with community agencies in your practice or identifying someone who can connect youth to services is vitally important to overall health. This is a tool that's within that document that can be used for organizational quality improvement initiatives. The key action areas are listed on the left side, the left column, and the recommendations are divided into basic, which are recommendations most primary care organizations should be able to meet. Advanced, those are recommendations that are more important for healthcare sites that see high-risk patients. And then specialty recommendations. So these include resources that are recommended by national model programs that specialize in the care of people who've been trafficked. What I really want to focus on today, though, are some of the more specific processes recommendations that we've been working on for healthcare. There are some great national examples and recommendations out there for how to create a response protocol for human trafficking. And these are a couple of them. This first one was created by HEAL. They recently published this toolkit for developing healthcare response protocols, and they're actually in the process of updating that now. Also, there are a few clinics throughout the US that have developed medical homes for victims of human trafficking. Mercy Family Health Center in Sacramento is a great example of that, and they've created a comprehensive guide that outlines the development and evaluation of their medical safe haven, which is their medical home for victims of trafficking. It's also important, though, that national guidelines are tailored to the organization based on state legislation and local resources. So HCAST has developed an example protocol based on HEAL recommendations for protocol components and examples in the literature. The accompanying resource, which is on the right, the protocol development resources, provides resources to help develop practice guidelines in healthcare organizations. So this is the document that has those screening tools I mentioned earlier. These were developed for Milwaukee providers, but they also could be modified to incorporate local resources and fit into existing processes anywhere. So I don't want to go through these step by step. You have them in your handouts, but recommendations in the literature for best practice healthcare responses include some common themes that I did want to point out. Again, I'm not going to focus too much on screening. You can find screening examples in that handout, but once concerns for trafficking are known, these are some of the recommended steps. It's important to assess for and address safety first, as well as healthcare needs that are commonly associated with trafficking. And then secondly, assessing for basic and psychosocial needs is important. Then finally, connecting the patient with trafficking-specific community resources. When considering safety, there are some important questions you may want to ask when someone discloses trafficking. These questions and responses were recommended by law enforcement representatives of HCAST, so things they felt were important for them to know so they could respond appropriately. If there's an immediate safety concern, you can contact security if available. Not every facility has security available, but working with your facility to create a plan to de-escalate these high-risk situations and making sure that it's known to providers before the situation occurs is important. If trafficking is a concern, you'll have to report to CPS or law enforcement if it's a child. Make sure that immediate safety concerns are communicated to those agencies when you make those initial calls. Ultimately, if the youth wants or needs to leave, we don't have the ability to hold them, and trying to do that might compromise their safety. But you can pay attention to identifying information like clothing, license plates, etc., which can be really helpful to investigators. You can also try to develop a safety plan with them before they leave, and there are some resources for this, again, in your handouts. I think it's section 6 of the development resources. After attending to safety concerns, no matter what your specialty, if you know someone who's is being trafficked, the treatment plan should include all of these components if the patient agrees and your clinic is able to provide them. Given the high rate of violence and trauma experienced by victims, all should be screened for psychiatric illness and suicidal ideation. Remember, injuries may be in areas covered by clothing, so examine them in a gown if appropriate. For example, putting a child in a gown for mental health assessment obviously isn't appropriate. Always assess the need for reproductive or sexual health services. We recommend testing for sexually transmitted infections for people who are working in the sex trade at least every 6 months, preferably every 4. Remember, victims of trafficking often don't have the option to use condoms. So educating them about the availability of medications to prevent infection after an assault is important. I mentioned earlier, PrEP or pre-exposure prophylaxis to prevent HIV. That's something that can be life-saving for them, but only if they're able to take that medication regularly and comply with the blood work that's needed to monitor for side effects. So that might be a big ask for many youth, but it's important to have a provider that can manage PrEP in your referral network. And then screening for substance abuse is also important as well, considering the high incidence of substance abuse in this population. According to survivors, these are some of the other important healthcare services that providers should have in their facility or be able to refer patients to. Having a list of referral sites for these services is recommended. And if you can find providers in these areas that have experience working with high-risk patients and survivors, that would definitely be preferred. Some providers don't think about some of these services like dental care, tattoo removal, referral sites for hormone therapy, but they have been cited as really important by victims. I also want to point out the importance of bridging services for substance abuse. Residential treatment for substance abuse disorders is often hard to get into quickly, but putting someone addicted to opiates on Suboxone to curb the craving until they can get into more intensive treatment programs can really help their chance of success. In terms of the sexual assault exam, some patients will refuse it because they think their purpose is to collect forensic evidence. But we would never force a teen to have any part of this exam that they don't want. Even if we don't collect forensic evidence or they don't want us to photograph their body, explain to them that we can still treat any injuries, we can test and give medications to prevent infections and we can also help them access other resources for basic needs. And really, sometimes the most important reason to have this evaluation is to reassure the youth that their body is healthy. So I think most of you are probably familiar with healthcare sites that can perform sexual assault evaluations, but here are some links to specific programs in Wisconsin. Another really important point is remember that because access to care is so poor, they may not have the opportunity to follow up for these services somewhere else. So if you're capable of providing them in your clinic or in the emergency department, please do that. When you make referrals to other services, it's best to utilize warm handoffs where you contact the referral agency directly to discuss the patient's needs. Health literacy can be a big issue for this population and information can get lost. So it's also less traumatic, I think, if the patient doesn't have to tell their story over and over to every provider that they see. Just make sure you're getting permission and documenting consent before sharing the information. For many reasons, including fear, trauma, and control by traffickers, patients may refuse medical services, and they have a right to do that. But if that happens, offer them a partial evaluation. Encourage them to come back when they're ready and that you'll be willing to help them. Then provide appropriate community resource recommendations depending on their needs. So there are some guidelines for mandatory reporting in your handouts. I'm not going to go over those specifically, but they're there for you if you need the information. And then I did want to mention this guide. This is the Wisconsin Child Sex Trafficking and Exploitation Indicator and Response Guide. This was developed by the Department of Children and Families as a way to create a common language for what we're considering concerning. One important thing about this is that children who fall into this at-risk category, this is very broad. Even though we're reporting this, not every case will be screened in for an investigation. This was just meant to give us a common understanding of some of the risk factors. And then finally, resource needs according to survivors. These were developed by our Survivor Advisory Board. In addition to accessible and low-cost medical and mental health services, these are the types of services that resource lists within organizations should contain. So safety from the trafficker or sometimes from an abusive caregiver is extremely important. A place to stay for themselves and for loved ones. Some are afraid to leave because they're worried the violence will be directed at a loved one or pets living in the home. Sometimes the reason for entering the sex trade was for survival needs for the youth and the youth family. So job skills and education opportunities are important. In some cases, their identification has been taken, or they may need legal help to expunge their record so they're able to find decent employment when they reach adulthood. Peer support, in particular, again, from those who've had similar experience, was the most commonly recommended resource in our focus groups. And then this is a resource list for youth that was developed by POSI. You can contact Rebecca. She's our coordinator for hard copies of this. And I mentioned before, HCAS is working with 211 to help build their list of trafficking-specific resources. We're also working to help connect them to community agencies for their Impact Connect project. This is a partnership between 211, health systems, and community health centers and community agencies. The health systems and community agencies will share this online platform, which is called NowPow, where community agencies can post real-time information like their availability, what kinds of services they provide, what populations they serve, and that's accessible to healthcare providers. Providers can use this platform to create resource lists that are tailored to the needs of the individual patient, including their location. So for example, a provider could create a list of human trafficking resources for a patient that needs transgender-specific resources in a certain area of Milwaukee. Through this platform, community agencies can also let the provider know that the patient followed up and received services. So Impact Connect is starting up this project in a stepwise approach. They've started with housing, and now next they'll be moving on to violence prevention and response, including human trafficking. So look for more information about that later. And this is our mailing list. If you'd like to get information about meetings, please email our scheduling coordinator. We'd love to have more input and help developing resources. So I know I'm a bit over. Do we have time for questions?
There's no questions.
Okay. All right, then thank you everyone for listening. And here are the instructions for claiming credits.
Thank you, Dr. Rabbitt. I'll ask you to leave the attendance slide on the screen for a couple minutes. Attendees, if you have not already done so, you may now text the attendance code and complete your evaluation. Please join us for next month's webinar on neonatal skin conditions. Thank you for being with us today.